I'm so happy to welcome everyone this morning. As we've been doing every week, we want to first start by briefly mentioning one of our new faculty. So today I want to make sure you're aware of Dr. Gabrielle Goldberg, who's one of our really wonderful new primary care faculty, seeing patients at the Ansonia practice at 74th Street and Broadway. It's been a delight for us to have Dr. Goldberg, who completed her training at Icahn Mount Sinai and joined us last spring. So please be aware of Dr. Goldberg for patients of yours who may need a really wonderful new primary care physician. Today, we're thrilled to have Professor Mariana Figueiro with us, who is a professor in the Department of Population Health Science and Policy, and also director of Light Health and Research Center, all at Icahn Mount Sinai. She completed her Bachelor of Science in Architecture and Urbanism at the Federal University of Gerais Minas in Brazil, and then completed her master's and her PhD at Rensselaer Polytechnic Institute in New York, where she started her career, ultimately rising to professor and leading their Light Health Research Center as well before joining Mount Sinai in 2020. Dr. Figueiro has received many awards, and the breadth of her work as a basic scientist, as a materials person looking at new ways to measure the impact of light on human health, and also her really very public work as a public intellectual, bringing us as physicians, for the scientific community and the general audience into a better understanding of the importance of light in health. It's been really remarkable. To give you some sense of the breadth of her work, she has been able to show the importance of light through her research, for example, for personnel working on submarines, for students attending middle school, for patients with Alzheimer's living in nursing homes. And that gives you some sense of really what she's done to really bring us further an understanding of light as a non-pharmacologic application with many, many important implications for humans and how they live and the health of their living. She's also looked at glucose metabolism and obesity. She is a fellow of the Illuminating Engineering Society of some stature. And again, it's really a delight for us, Dr. Figueiro, to have you with us today. And we're so excited to learn more about light and its importance for us, our families, and our patients. So thank you for being here.
Well, thank you very much for the very kind introduction. I think I'm going to hire you at the center to just go out and talk about our work. So I'm glad that we are evangelizing people already. So that's nice to see it, because that's really my sort of my goal in life, is to do that. So let me share my screen. And I'll talk a little bit about some of the most recent work that we've been doing. And again, we don't have time to go over a lot of the projects, but feel free to reach out, and it's a good connection to know, you guys know me and I know you, so that we can just continue the relationship. I had a great background, but people are a little bit confused about who we are. We actually were part of RPI at upstate New York. And I know Mount Sinai used to have, or I think they still have, a relationship with RPI. But we have expanded a lot in this area of light and health. So what we decided to do was to move to Sinai. Now, what we're making a little bit of a confusion here at Sinai is that we are maintaining a satellite lab in upstate. So Sinai is actually renting a space there. It's currently under renovation. So we're going to maintain the 20 people that came with us are going to be working in upstate, and I'm going to be back and forth in the city and upstate. In fact, I just came in last night from upstate. So we're very excited about being able to link, I think, the science of light, the understanding of the measurement of light, into the application with patients and with basically any population. We're not limited to humans. This is one of our biggest programs, but we're also working with things like plant health. So we're using light to actually reduce pathogens in strawberries or or grapes for wine production, for example. We're looking at transportation safety and how we can use light to minimize accidents on the roads or improve pedestrian safety, for example. And obviously energy and sustainability, and the design part is really the branch where we implement some of these things. And we're actually trying to make some difference in the lighting in the hospitals here at Sinai, which I think could use some improvement. Don't tell anybody I said that. I know it's being recorded, but I'm trying to evangelize people to do a little bit of better job. So they're all like very surprised about the lighting we're putting in our labs up there. And like, why do you need fancy lighting? I'm like, this is not fancy. This is what we need. So let's just, make sure we get better lighting everywhere. So I'm going to focus a little bit on the health area, which is, one of the largest program that we have in the center. And the premise is really looking at circadian rhythms, knowing that they are biological processes that display an endogenous and entrainable rhythm that it's close to 24 hours, circa about Ds a day. As you all may know, circadian rhythms are generated and regulated by a biological clock in the suprachiasmatic nuclei in the brain. If we are in a dark cave for many days, and I can tell you some of us in hospitals are in dark caves for many days, even though we don't see it as being dark caves, but we definitely are in terms of impacting our circadian system. We have a circadian rhythm that free runs with a period slightly longer than 24 hours, on average about 24.2 hours. So what we need is a very robust light-dark pattern so that daily we are synchronized and entrained to the local time on Earth. Otherwise, it would be your biological clock telling you it's 6:30 in the morning and your alarm clock telling you it's 7 o'clock in the morning, and you don't want to get up because you still want to sleep for that extra half an hour. So we need that daily resetting of the biological clock. And what we're learning is not having that robust light-dark pattern has a major impact on health and well-being. So here's just examples of how that circadian disruption or that lack of entrainment between your biological clock and the external time can affect health and well-being. And this is a cartoon. I love this cartoon. It's about a shift worker. And I think all of you in this meeting today understand what that is. It's really being completely disrupted. It's like being jet lagged continuously. And you can have short-term decrement in performance, sleepiness during the day. But if you continue to do that for many years, you can have much more serious risks, such as increased risk for cardiovascular disease, diabetes, obesity, and even cancer. So part of what we've been doing is really understanding the impact of light on circadian disruption and on these maladies. And then we just got a new grant now that we're going to be looking at how do you develop lighting schemes for shift workers, for example, so that you try to minimize that circadian disruption. Obviously, it's not something we can fix just with light because there's more to it than just the light-dark pattern. But at least if you can help and minimize with something, that would be, I think, useful or at least practical for hospitals and patients. So this is a study that we've done some time ago, and we have done further studies, and we're going to continue to do a little bit more of animal studies in this area. It was really looking at light-dark patterns that we generated mimicking what a day shift nurse is exposed to, which we're considering a 12 light, 12 dark. So it's more of a regular light-dark pattern. And then somebody that works one rotating night shift or somebody that works 3 rotating night shifts. And then we put these animals in this light-dark pattern for 7 weeks. And what we saw was clearly, even with one night of rotating shift work, we saw an increase in glucose area under the curve when we did oral glucose tolerance tests in these animals. So basically, you do become pre-diabetic by having this sort of rotation. And to my surprise, when we did it, we thought that we were going to see sort of a 1 night and a 3 night on a dose response. And we really saw that just 1 night was enough to mess up your system at least. Now, this was a short-term study, so part of what we've been doing right now is looking at the long-term study. So do you have an adaptation to that or not? Or if you bring it back to 12-12, do you reverse some of these negative consequences? The other area that we're also working with, and that's part of the new grant that we just got, it's looking at circadian disruption and cardiovascular disease. This was also a pilot study that we collected that led to this new grant where we exposed mice to 18 weeks of a 3-day rotating shift work, and we use the LDLR mice, which is mice that are prone to have cardiovascular disease. And what we showed here is these are images of the heart, of day shift and rotating shift, and then we measure some outcomes associated with cardiovascular disease. And we saw that in the rotating shift work, which is the red ones, you had a significant increase in atherosclerosis lesions, you had a significant decrease in the collagen, and you had a significant increase in necrotic cores. All of these are associated with increased risk for cardiovascular disease. Now, it's very interesting because in addition to that circadian disruption, you also have sleep deprivation, okay? Typically, they go hand in hand. If you're disrupted, you are also going to have a circadian sleep disturbances. And the reason is that the sleep-wake cycle is very much influenced by your circadian clock. So we have a 2 processes model with a sleep-wake cycle where you have the circadian system that sends you an alerting signal during the daytime hours and a sleeping signal during the nighttime hours. And that really guarantees that you have this robust light-dark pattern, robust sleep-wake cycle. So you're awake for 16, 8 hours a day, and you're asleep for 6 to 8 hours at night. So that's sort of what we're supposed to be doing if we're regular daytime people. And then you have what we call the homeostatic pressure. And that's the reason why all of us have a cup of coffee right now in the morning is that, with your homeostatic pressure, what happens is in the morning you wake up, you do have a low homeostatic load, but you don't have your circadian clock sending you that alerting signal as much. But as the day goes by and you stay awake, you actually increase that sleep load. And that's what coffee does. Coffee really, once you increase that sleep load, you increase adenosine production by the body. And then what you're doing with caffeine, you're really blocking those adenosine receptors. So you're trying to minimize the effect of this sleep load that you're getting over the course of the day. And your biological clock is also counteracting that. And then what happens at night, because these things are aligned, is your biological clock shifts to sending you a sleeping signal. You have very high sleep load and you fall asleep and you have a very nice consolidated sleep at night. So maintaining the alignment between these 2 processes is very important for maintaining good sleep. So, one of the questions is when I did my PhD, my advisor wanted me to answer the question, why do we sleep? And I said, I want to graduate. This has been a question that a lot of people are trying to answer, and I don't think I'm going to be the one trying to able to answer it in 4 or 5 years. I think it's a noble question, and I think there has been a lot of new work done about the glymphatic system. And how the hypothesis is that, when you sleep at night, especially during deep sleep, that what sleeping is doing is it's cleaning up the debris in the brain that you accumulate during your wakefulness. And that has to do with the glymphatic system coming through the blood-brain barrier, going through your brain, the spinal cord fluid, cleaning up that debris in the brain. So the hypothesis is that if you don't sleep, especially in deep sleep, which is the first 4 hours of your sleep, you're actually not cleaning up the brain. And there has been a lot of hypotheses about, especially now with Alzheimer's disease, that has been a risk factor for Alzheimer's disease. The other important thing is that sleep promotes learning and consolidates memory. So it's been a lot of studies, very interesting studies. You learn something in the morning, you repeat it in the evening, you have no change in performance. You learn something in the evening, you repeat it in the morning with or without a night of sleep. And when you don't sleep, you do worse. When you sleep, you do better. So those of us who pull all-nighter for an exam the following day, it's probably a bad thing. The best thing you can do is just learn a little bit in the evening and go to sleep, and you're going to consolidate your memory and do better the following night. Now, the consequences of sleep deprivation are very similar to the consequences of circadian disruption, because again, they go hand in hand, even though some studies, and that's actually something I've been very interested in understanding, is what if you separate, like the studies we've been doing with the mice, it's really circadian disruption, but you're also doing sleep disruption. So if you can separate those two, try to find out which one affects what outcomes more. And I don't think we know yet, because again, they're very much linked, but some studies have done non-circadian disruption with sleep deprivation, and they have shown very similar impact on reduced performance, increased risk for diabetes, obesity, and cardiovascular disease, increased risk for depression, Alzheimer's disease, and also, interesting enough, increased risk for falls. And at the end, I'll just give a little bit of a snippet of some work we're doing looking at falls risk, and hopefully we'll do a demonstration here at Sinai. So I guess the question, obviously, that everybody's asking is, well, how does light affect sleep and circadian rhythms? And why is it that we have a whole center that it's dedicated to understanding how we can use light to impact health and well-being, and, basically through the impact of light on sleep and circadian rhythms? And you can categorize in three sort of big chunks. One is the entrainment of the biological clock to the local time on Earth. So that's really your resetting your biological clock daily, or when you travel multiple time zones, you are re-entraining to a new time zone. And in terms of the lighting that you need for that, there's a couple of things to remember. One is you are a blue sky detector in that regard. So blue light is the most effective light for impacting the biological clock. Does it mean the other types of light, like an incandescent light, that it's warm, does not impact the circadian system? No. All it means is that you need more light when it's warm color to impact the circadian system than when it's blue color. The other important thing that we tend to be very confused about is that the light you need to affect your biological clock is a lot higher than what you need to affect vision. So those of us in basements or in very, dark offices, we can see very well. We don't have a problem doing our visual tasks, but it doesn't mean we're impacting our biological clock. And it may be that we are in biological darkness. And that may be things like seasonal depression that we do know is linked to day length, for example. It could be that some people can't readapt to that low light level, and it becomes that this person is in biological darkness. And so it starts being desynchronized with the local time on Earth, and you can have the health effects that we're seeing, for example, with seasonal depression. The second thing that light can do is an acute direct effect on humans. It's like a cup of coffee. You can give people light in the middle of the night, in the middle of the day, and you're going to have a perky effect. You're going to feel more alert. Now, what's most interesting about that, and we're doing a lot of studies trying to understand that, is that it doesn't have to be blue only. Blue does it, but we're seeing a strong effect with red light. And the beauty of that application is for night shift workers, for example, when they have their melatonin levels high, and melatonin is a hormone we produce at night in darkness, and it's been linked to a series of maladies, including the suppression of melatonin has been linked to increased risk of cancer in shift workers. So what we're trying to do is give them a lighting that will be a cup of coffee without suppressing melatonin and having the negative health effects that we would have if we expose them to blue light in the middle of the night. So again, we're trying to understand the stimulus so that we can then tailor for each of the interventions that we need to make the best of it. And then the third one is what we call perceptual cues. It's really very interesting work we're doing. I'll show some preliminary data we have that if you give people vertical and horizontal light cues, when they get out of bed, for example, at night, people in hospital wards or nursing homes, they are able to have better postural control and stability because they have the visual perception that feeds back into the perceptual system, and it helps with balance. So we have some data showing that it's very promising, and I'm working with Mount Sinai here to see if we can do that in hospital wards. So let me start with some of the work we've been doing on more of the biological clock entrainment one. And we're starting with the general population as well as with some fringe populations such as Alzheimer's disease. We're going to start some work with Parkinson's disease, cancer, and I'll show some of the data. But I'm also interested in the general population. And I can tell you for the general population, seeing an effect is a little bit harder because we all have sort of adaptation systems that are different for different people. When you're talking about Alzheimer's disease patients, they're sensitive, they're confined in a space where you can control the light, so it's a lot easier to see an effect. With the general population, it's a lot harder. But interesting enough, you can still see the sort of the indication that it makes a difference. So this was actually a survey that we did during the COVID-19 shutdown last year. It was in April last year. And we sent out these surveys. It got picked up by a couple of news channels. So we got over 700 respondents of the survey. And obviously we couldn't do any light measurements, but we at least asked people about their subjective sort of impression of their at-home light exposure, whether it was very dim to very bright, and then how long they were spending outdoors during the daytime hours. And what you see here, it's really nice. So when you look at sleep disturbances, sleep-related impairment, anxiety, and depression, as you increase the amount of light exposure at home, or you increase the time spent outdoors, you reduce sleep disturbances, anxiety, and depression, and then you improve positive affect. So what I thought was very nice about that is that everything went on the same direction. And it does look like that 1 to 2 hours a day outdoors would do the trick. Or if you are indoors, try to sit by a window or increase the amount of light that you have, because that should help as well. Now, that study led to a small pilot study we just finished, again, in real life application. And this was during COVID. It was end of last year. And this was a company that had this smart glass, which really allows a lot of the short wavelength, the blue light in, and it cuts out a lot of the heat and the sunlight. Because what happens is when you have sunlight hitting your face or your work, you tend to pull the shades, and then you lose all the daylight that comes from outdoors. And honestly, daylight is the best light source. If you can sit by a window without the shades being pulled, that's the best option for you to get your light. So we compare this smart window, which let the light in, and then the conditions where people would just pull the blinds and have sort of a clear window, but with the blinds pulled, so you wouldn't have as much light information. So we collected that on 20 residents. These are people living their normal lives in that building that happen to have that smart glass windows. And the study was 28 days, was a crossover study within subjects. So this is just the demographics. They were pretty much young people, tend to be very late people. So they tend to go to bed after 11 o'clock at night. Everybody working from home at the time. Nobody was going out because of the pandemic, and just, regular healthy individuals. So what we did is we crossed over. 10 participants started with the smart window condition, and 10 participants started with the blinds conditions. And then we had a sort of baseline washout period in between, and we reversed the conditions. So during that, we collected environmental monitoring. So we had just how much light they were getting in the homes. We also had a personal light measuring device to check how much light they were being exposed to. We had an actigraphy, which is similar to a Fitbit type, that looked at sleep tracking. And then we were looking at surveys. So the last day of each week, so the last day of baseline, the last day of smart windows, and then the last day of baseline again, and the last day of the blinds, we collected saliva samples for dim light melatonin onset. So what dim light melatonin onset is the timing in the evening at which your melatonin level starts rising. And that is sort of a marker of the timing of the biological clock. Typically, if you're an entrained individual, you tend to start your melatonin rising in the evening about a couple of hours prior to your normal bedtimes. And that really is a trigger to tell your body it's time to switch from daytime to nighttime and get ready for bed. If you don't have that signal, or if you have that signal too late, you're going to end up not falling asleep early. And then we collected throughout the 24 hours some vitality surveys to see just how alert and how they were feeling during the day. This is just an example of the overall light exposure. We're using here a metric that we call circadian stimulus, which is really calibrated for the circadian system. So it computes the amount of blue light that you're receiving. And there was an increase in their amount of light that they were receiving with the view condition, which is that smart window condition. In terms of their melatonin levels, it was very interesting. We did see that in the dim condition or the blinds condition, there was a delay in their melatonin onset by about 15 minutes in just 6 days, which doesn't sound like a lot, but it's pretty significant considering the short amount of time. So in other words, you're delaying that signal that it's bedtime to your body by not being exposed to that morning light. We also saw, which was very interesting, was a delay in the sleep onset, which is consistent with a delay in the melatonin onset. So they tended to fall asleep later in the blinds condition than in the windows condition. And what was also interesting, on the weekend, they actually tend to sleep a little bit longer on the blinds condition, which means that you're catching up in more sleep depth or sleep deprivation. The other thing that we found was sleep duration. Obviously, if you're going to bed earlier, you tend to sleep more with the windows conditions. And there was also something very interesting. We call it sleep regularity index, which is really how regular your sleep is. And obviously, the more regular, the better. And we did see that there was increase in that regularity of sleep with the windows condition compared to a reduction in that regularity of sleep when they were exposed to the blinds condition. Not moving very fast. And then we did see, in terms of the mental health, there was a decrease in anxiety, a decrease in stress, and an increase in mood with the windows conditions. So the summary here is, which I think it's the important part that we are looking at, is light during the day matters. And it matters because it helps you start suppressing or start producing your melatonin at the right time. It helps you go to bed earlier, and it helps you feel better during the day. So better light during the day actually is showing better sleep at night, which is what we all want. Now, in terms of the more fringe population, so this is more of the clinical population that we're also looking at. This is a study that we did here at Mount Sinai. It was an NCI grant, R21, and with those pilot data, we just got a good score and an R01. So I think we're going to expand the work and hopefully do more of that study here at Sinai, because this was actually a study that we were doing with the myeloma transplant patients. So we were delivering the light inside the hospital room. So we do know that these patients, they do experience a lot of transplant-related complications, including elevated symptom burden, such as depression, anxiety, as well as high rates of neutropenic fever and dysregulation of their pro-inflammatory cytokines. So the other important thing to take into account, which makes it even worse, is the fact that compared to cancer-free controls, the circadian rhythms, and they're measuring basically through rest activity patterns, this is what the circadian activity rhythm metric is, tends to be disrupted before and after the chemotherapy. So it seems like not only the disease disrupt the cancer patient's circadian rhythms, but also on top of it, the chemotherapy does that. And we know that they have a lot of issues with fatigue and with sleep disturbances. So what happens is that sort of disease plus the circadian rhythm disruption, it augments all these negative effects that are occurring, especially in this population. So we're seeing an increase in the disease burden and inflammatory cytokines, as well as we're actually seeing a disruption in their melatonin rhythms, which is a marker of the biological clock. So our hypothesis for this study is that since light is a strong synchronizer of circadian rhythms, we were looking at, well, if we give light during transplant, and that means while the patients are in the hospital, because they're inside a hospital room for 2 weeks or 3 weeks sometimes, can we deliver a robust light-dark pattern there to help minimize symptom burdens, increase their melatonin levels at night, so that's an indication of being more entrained, reduce the pro-inflammatory cytokines, and reduce the neutropenic fever. So that's what the pilot study was, and we're going to extend that in the new grant. So for the pilot study, we had 44 Mount Sinai Hospital patients, and we split them into an active lighting intervention. We call it circadian effective light, or circadian ineffective light, which was really a light that was put in the room, but it was dim and not effective for the circadian system, but they were getting something because they were part of the study. So this is just to give you an example of the amount of light. So we were looking at, 10 times, more than 10 times more the amount of light in the active lighting condition compared to the control or placebo lighting condition. This is actually the fixture that we built with a manufacturer we collaborated with, and it was on wheels. So we kept wheeling these things to different rooms whenever we enrolled the patients. And we actually have these fixtures in our offices now because the offices look really nice with the fixtures. So it's a lot better to have the fixtures up. The dim one was the same fixture, but you didn't really give as much light. So the idea here is it's completely passive for the patient. So you don't really need to sit in front of a light box. You don't need to have any effort. Your entire room is lit up in a way that you are getting that lighting intervention. So we had a baseline that was performed before the transplant and before they got into the hospital, which typically was 1 to 2 weeks and no more than a month before they had the transplant. And then we collected data 2 days post-transplant, 7 days post-transplant, and then on the third day of engraftment, which was approximately 14 days after the transplant. In terms of depression, we did see a significant decrease in the depression, especially at 14 days after the transplant. So those receiving that bright light or the active light were less depressed, reducing symptom burdens. This is melatonin levels. So we collected overnight urine melatonin. And what we see here is this is the group that was in the bright light, and this is the group that was in the dim light. So at baseline, they actually increased the amount of their melatonin levels at night with the active intervention. And with the placebo or the control intervention, they actually decreased the amount of melatonin. And there was a significant difference between baseline and intervention. So basically, what we did here with those lights is we maintain entrainment. By being in the hospital in dim light for 2 weeks, they were starting to lose entrainment. So they're starting to reduce that melatonin production at night. And all we did with the lights is we just kept them entrained. So it's always like a maintenance protocol that we were doing with the light. We also saw that there was a lower IL-6 scores in the group that received that circadian effective light. And they had significantly less a likelihood of developing a neutropenic fever. And that we just looked at their charts, and we did see that they actually had experienced fewer fevers with the bright white light. So this was a pilot study. That's why we have the R01 now to expand that. And anybody interested in enrolling any patients in the hospital, we're going to start enrolling hopefully beginning of next year. But we did see a reduction in the depression, an increase in the overnight melatonin levels, a decrease in the pro-inflammatory cytokines, and also a decrease in the rates of neutropenic fever in the myeloma transplant patients that receive that circadian effective light. So promising, but hopefully we'll be able to extend that to the next phase of the study. The other population we've been heavily involved with is with Alzheimer's patients as well as mild cognitive impairment patients or MCI patients. We know that Alzheimer's disease and related dementia as well as mild cognitive impairment patients, they do have sleep-wake disturbances. And that's actually one of the reasons why they are institutionalized, because it's very hard on caregivers. They don't have this consolidated rest activity patterns like we do, where it's active during the day and sleeping at night. They're pretty much almost like in their homeostatic system. They sleep for 3 hours, they wake up, they sleep for 2 hours. They're awake in the middle of the night wandering. So it becomes really hard for the caregivers to care for them. Now, the other thing is that it's the chicken and the egg part. There are some studies showing that they actually that the sleep-wake disturbances may actually be one of the earlier symptoms. So obviously, when you have the AD, you actually affect your sleep. It makes it worse, but you may already have sleep-wake disturbances prior to having diagnosis of Alzheimer's. And of course, the work that it's been doing now, looking at sleep and how sleep cleans up the brain, and they're now considering sleep as a risk factor for Alzheimer's disease. So we have been very interested in treating the symptoms. I can't say we're treating the disease or we're minimizing the risk of Alzheimer's disease. Maybe one day we can say that, but I don't think we have enough data to say it. But I do think we have enough data to say that it helps with the symptoms. So this is just one of we did now 4 or 5 studies, but this is just one of them where we had 2 studies. One was, we call it a short term, which was a randomized placebo control where they had 4 weeks on an active lighting intervention, 4 weeks of washout, and then 4 weeks on a placebo or control lighting intervention. And we collected data at baseline, before the lighting intervention, and then on the 4th week of the lighting intervention. And then we followed the patients for 6 months. So we also did a long-term, but that was just a single arm where they served as their own control. We collected baseline, and then we came back and we collected data at weeks 9, 17, and 25. So for the short-term study, we did see a reduction in sleep disturbances, and that the data I'm showing here are the questionnaire data, but we did see actigraphy data as well, where there was a significant decrease in their Pittsburgh scale quality index score, which is a sleep disturbance score. And compared to on the active lighting intervention, we see a significant decrease. In the control, we see a little bit, but it's not statistically significant. And when you take the difference between baseline and intervention, you see a significant difference with the active lighting intervention compared to the control. Same thing with the depression score. So there was a significant reduction in depression scores, and it was a significant reduction in agitation scores. So one of the things with the agitation and the depression, I've been very interested in expanding that to things like delirium in the ICU, or, I know a lot of people with cardiac surgery recovery have some issues with agitation and delirium. So we were thinking maybe that could be an application that we could expand to. Now, in terms of the long term, I have to say this is probably one of my favorite results that we got from the study, because if you look here, on the sleep disturbances, the depression, and the agitation, you see that there's a continuous decline over the course of time. So if you think about Alzheimer's disease for 6 months, they are deteriorating in their disease. And yet, with the light, we are able to see an improvement in the sleep disturbances, and the depression, and in the agitation. So I think that, to me, it's a simple solution. It's non-pharmacological. It should be every nursing home, every assisted living facility, everywhere we could implement that should be implemented. There's no reason why we shouldn't do it if we're seeing such positive results. Now, we are recruiting for MCI and ADRD projects. We currently have 4 grants that we're running, studies from people from living at home to assisted living. So please contact me if you have any patients or anybody that might be interested. We're absolutely recruiting for that. Now, one of the things that we're also interested in understanding is, are we making a difference in the disease itself? So this was actually a very small animal study that we did, and we're expanding that now, where we looked at the 5X FAD animals, and we had controls, half males and half females. And what we did is we exposed them to a robust light dark pattern. This is not circadian disruption. It's simply comparing having a robust highlight levels compared to low light levels. So highlight levels during the day, low light levels at night, or for mouse was the opposite. But think of it as adding a circadian effective light in the environment, or maintaining them into a low light level and a little bit lower in the evening. That's what you have in nursing homes right now. So it's dim dark compared to bright dark, okay? So we wanted to see, does it make any difference? So we exposed them to these 2 conditions for 7 weeks, and then we repeated the protocol to be able to get them back and forth in terms of their circadian system. And what we see is, as expected, we looked at cortical A beta 42 levels. The 5X FAD animals have a much greater A beta 42 levels, and that's what would be expected. But what we found, which was very interesting, when they were exposed to the bright dim condition compared to the dim condition, there was a significant reduction in that A beta 42. And obviously there was an interaction. That effect was much greater in the 5X FAD animals than it was in the controls. So what this is suggesting is by exposing the animals to a very robust light dark pattern, you're actually seeing an impact on beta amyloid deposition. So we're trying to do some imaging studies here with Sinai to see if we can see some change after a lighting intervention, to see if we were doing any changes with that. Now, very quickly, because I know we're almost up in the hour, but I wanted to very quickly talk about the acute effects, and that could be a whole new talk just on the acute effects, but I just want to touch on that and then on the falls. So this is actually a field study we did. It was sponsored by NIOSH, looking at day shift and night shift nurses. As I mentioned, we're very interested in delivering red light for alerting a cup of coffee without affecting the biological clock. So this was actually a 20-week protocol. We had day shift nurses from 7 to 7 and night shift nurses, again, from 7 p.m. to 7 a.m. And we collected a series of outcome measures, and we're still actually analyzing some of those data. So they had intervention sessions. So they collected baseline for 2 weeks, and then they have in the intervention sessions for 2 weeks, and then there was a washout period. So it was a very long study. It was almost a 20-week study. And it was a crossover within subjects. So they were exposed to either blue light, red light, or white light control, which was a low light level, just as a control. And we gave them on light goggles so they could move around. They didn't have to be sitting looking at the light. And we collected data at the beginning, the middle, and the end of the shift, because of course they were working, so we couldn't really ask too much from them. So this is just the sort of an idea of the protocol. So we had basically, we had the baseline week, which was 2 weeks, and then the lighting intervention week, and then the washout. And then within each of the weeks that we were collecting data, we were looking at the subjective sleepiness, which is the Karolinska sleepiness scale. We were looking at biomarkers, cortisol and melatonin levels, and we're looking at short-term performance. Here are just preliminary results on the short-term performance. This is, one back response time. So it's basically a lower response time is better performance. And we did see with the red light that there was a significant decrease compared to baseline. There was a significant decrease in the reaction times. Same thing is with another short-term test, which is the one back correct no match, we did see again a significant decrease in their response times. So it seems like we're seeing a faster reaction times. And I do think that the red light, it's almost like it's impacting your flight and fight system. So you're going to react fast. And we're consistently seeing that. We're just finishing up a study with Mayo Clinic where they're looking at fMRI and looking at what's happening in the brain and what parts of the brain are being affected by both the red light and the blue light. And then the last thing I want to talk about is reducing fall risks. We do know that this is very serious in nursing homes and elderly care homes, but it's also serious problems in hospitals. And they've seen in hospitals that there's a really, it ranges from 1.3 to almost 9 falls per 1,000 bed occupied days. So it's a big deal, falls in hospitals, and obviously falls with injury, it's even worse. So, you know, one of the times when people tend to fall most is when they get up and try to go to bathroom, for example, especially in the middle of the night or any time during the day in the case of hospitals. So the idea is, can you create sort of a lighting intervention that would give you these horizontal vertical cues? And the idea is you put it in the bathroom door. So first of all, you know where the bathroom is, and that's particularly true for Alzheimer's patients in nursing homes. And second, you have that horizontal vertical cues that help you provide sort of a perception of the environment. We've done some lab studies with that where we had people looking at those horizontal vertical lights, and then we tilted to the right or to the left. So you had the visual stimulation, but you didn't have the perceptual stimulation. And what we found was, especially with people that are high at risk for falls, we saw that these horizontal vertical lights were actually in things like the weight transfer time, for example, they were reducing weight transfer time to make it just as close as increasing ceiling lights. The disadvantage of turning on ceiling lights in the middle of the night is that it can disrupt sleep. So the idea is, can you give a night light that will not disrupt sleep, but will still give you that horizontal vertical cue or that idea of the environment so that it minimizes risk for falls? So in the lab, we did see positive results. So what we did is we did an R21. We work with UNC on that. And we install these in nursing homes and assisted living facilities. So this is an example of one of the installations that we did. And we collected the data over the course of, I think it was 6 months, but then we had to stop because of COVID, but at least we had some data. And we were looking at video cameras, and then people were evaluating falls or near falls incidents. And what we saw was actually a 34% reduction in falls due to the lights when we did that in assisted living facilities, nursing homes with patients of mild cognitive impairment and early Alzheimer's disease. So we did see that in the field, just by giving these night lights, it does help minimize. So we actually have a grant that we got a good score, like a borderline score, to extend that in assisted living facilities. And I've been working with Mount Sinai to see if we can maybe do a demonstration here and collect some data here. Now, one of the things that we're also working on is things like personal medicine. So coming up with, devices that continuously measure your light exposure, sends it to an app, and it tells people when to get light and when to remove light. So it's almost like a light prescription for people. So we've been doing some modeling and some work in that area as well. So just summarizing, I think circadian rhythms are the platform for all biology. I do tell people, consider time of day of your studies, of your drug intake or anything, because it is very important. And one of the things is promotes entrainment to local time on Earth. So part of it could be chemotherapy, Alzheimer's disease patients, any application. We're starting with Parkinson's disease, traumatic brain injury patients. So we're looking at all these different populations. And then light also has an acute alerting effect, which is really almost like a cup of coffee. I want to acknowledge and thank for the invitation and our project sponsors. We have a lot of funding from NIA, which has helped us a lot with our information. And thank you for your attention.
Thank you so much, Dr. Figueiro. I think we have time for questions now. I see you can post the questions in the chat or unmute yourself. I see Dr. Mensah has raised her hand.
I have several questions. First, it's a wonderful presentation. Thank you so much. The light is such an important feature, and I felt that we needed studies on this a long time ago. But what I wanted to ask specifically is many elderly patients, especially when they're alone, they use TVs in their bedrooms all night long. So you have a light and you have noise, and they claim they can't sleep without it. The other is timing of medications can also alter sleep onset or sleep quality. So are there any hints that we can use? And then finally, of course, the changes in seasons, because the amount of light in the winter is much less. And how then can we help patients sleep better besides sleep meds, which I hate, but they tend to use it. And another thing people use is alcohol. So that to me is another disruptor. So could you comment on those elements?
Sure. Well, I mean, first of all, for the nighttime light, that's why we're trying to do this horizontal and vertical lights, because they're low light levels. They go on occupancy sensors. So in other words, they're only on when people are moving in the space, and that helps a lot because you can have a delay off so they can come back to bed safely. And then after 15, 20 minutes, when they fall asleep, it just turns it off automatically. And then when they move in back, we do have the cat problem with that, because if you have a cat or a dog, they're going to be turning on and off those things. So there's always adjustments for that. But I agree that it has to be low light levels, and if you can do it on an occupancy sensor, at least it helps a little bit in that regard. Regarding the time of day of medication, I completely agree, and I know that there's some fascinating work looking even at the effectiveness of medication depending on time of day, and that's true with chemotherapy and so on. I think this is an area that I haven't worked as much, and I would love to increase the work in this area because I think it's very important. But I do know that there are medications, like they even talk about prednisone or medications like that, where take it in the morning, don't take it at night, because it can impact sleep. And then the third thing is you asked about the seasonal part. It's absolutely true. And that is why we're trying to change lighting in people's homes so that that lighting is increased during the day, regardless of what's outside. If you can go out, that's the best option, but a lot of elderly people can't. So I want to be able to increase that light so you can tell people to just add 2 or 3 more of the lamps. And we have some tips on our website. We've done a couple of videos, so I'm happy to share that you can share with patients on how to implement that in your house. And alcohol, it's absolutely true that there has studies been showing that alcohol, it seems like it helps you sleep, but it really doesn't, because it is affecting your deep sleep and your REM sleep, your type of sleep. So it's definitely not a good way to help people fall asleep. So I think maintaining regularity, especially regularity of the light, is very important.
Thank you. I think Dr. Mensah can ask next. Thank
you. Fantastic talk and well timed for the season. I wonder, with us as professionals working in environments where the lighting is not optimal, what do you think from an institutional level that, say, Sinai can do to improve the quality or the type of light that would stimulate the daytime light that one would have, i.e., for example, in residents' rooms where they're doing their charting, or on the floors where they're moving about, since they really don't get the opportunity to spend a ton of time outside?
Yeah, I've been trying. I said, work with us. I really want to work with Sinai to help with some sort of guidelines on how to get better lighting. It can be done nowadays. The technology is there. It's available. It's not that expensive. And so I think that it's just a matter of increasing the amount of light without obviously making it uncomfortable. So it can be done. And as Sinai is renovating and changing, I think, I'd love to work with Sinai to do that. And I've been talking to, David Rich and other people, the dean, and I think people are starting to get awareness. It just takes time. But increase the amount of light. And if you are in a space where you don't have that, go outside if you can. Go do a phone call outside or go get your lunch and sit outside. At a minimum, that's good for you if you can move. With patients, open up the shades, open up the windows, make sure that they are getting as much light as they can during the day. And minimize the light at night. We in hospitals tend to be very, very unkind with patients in the middle of the night by having very high light levels, interrupting at night. And I know vitals are important and so on, but if we can change practice like that, we can help at least sleep a little bit more with patients. And I'm sure that's going to be beneficial to everybody.
We have a question from Dr. Baskin in the chat, and then we can ask Dr. Seward for his question as well. So Dr. Baskin asks, how many hours are needed for positive effects of lighting from windows or outdoor exposure to see any effect?
We're seeing 1 to 2 hours, at a minimum 1 hour. And obviously with older people, they tend to have less light reaching the retina for changes in the aging eye and so on. So I like to put more, a couple of hours sitting by a window or in a porch or anywhere that they can get more light. That would be my recommendation. And do it every day at the same time. Morning is better. Okay, the earlier in the morning, the better it is.
Professor Figueiro, I'm guessing that it's easier to enroll patients in your trials than it might be for some pharmacologic trials. And I just wondered if you'd comment on that, what you hear from patients about why they're interested in participating. And again, I could be wrong, but that's just a guess I have.
Yeah, I mean, I have to say we are starting recruiting. We are having barriers on recruitment, mostly because of COVID and because we have to come in patients' homes to at least install the lights. And that has been a barrier. But what we get is really the fact that is non-meds. People want to get out of meds. People want to be able to do something. It's not unlike diet and exercise. If you decide you want to be healthier, you're going to go on a diet or exercise or, and it's the same thing with light. And the beauty of light is that it's so passive. It can be passive if we do it right. So I think that that's what the patients really like. And the biggest reason why they enroll is sleep. They don't sleep well. And they really want to find something that they can sleep well without medication.
I don't see any more questions in the chat. If anybody wants to ask a question, now is the opportunity to unmute themselves.
I actually have a comment, and this is a long time ago. When I did a study on patients with COPD, I found that the patients with similar degrees of abnormalities of pulmonary function had different levels of compensation. So patients with FEV1s of 40%, those who had hypercapnia had sleep disturbance. It was because I was trying to find out what the difference was. Looked at their symptoms, looked at their medications, looked at their lifestyle, everything else. And the major feature was that they had sleep disturbance. So that was in 1972. Ooh. So I said, something's wrong with sleep and we have to look at it. And when I went to my chief to say that we need to study sleep, they said I was out of my mind. Nothing happens during sleep. And I was bucking into the wrong terrain. That study still needs to be done because we see differences, and I think it would make a tremendous difference if we understood the sleep disorder that occurred, because these are people who are revolvers in the hospital. They come in hypercapnic respiratory failure, they get intubated, and we know that all that happens is increased morbidity and mortality. So that study is yet to be done, and I'm going to email you so I can.
And we're hearing a lot more now because of COVID, and a lot of people that have been, intubated because of COVID are having sleep problems or having brain fog or having a lot of things that are consequence of that. So I agree. I think the more we learn, the better it is, without any question.
Professor Figueiro, thank you so much for a wonderful talk and really for wonderful work. Super stimulating for us, and excited for a future that includes the impact of light on the health of everyone. So thank you so much. It was really great.
You. Thanks for having me, and be in touch if you guys have any patients or anything. So be in touch. Thank you for the invitation.